attendees there. I think we've got a lot on the agenda today, so I'll just propose that we move on, because I do want to make time for us to have a break in a hour and a half, hour and 3/4 sort of time, refresh our cups of tea or whatever. Just to let members know, we're going to have a swap of the agenda. We're going to take agenda item 4.1, blueprint for good governance. We're going to take that immediately after matters arising, just to allow Ruth to go up and do other things rather than sit through the entire meeting. So if everyone's happy, that we'll do that, and we'll do a bit of scene setting of each of the items as we work our way through. So we will move on. So welcome to everyone today to the, what seems ridiculous, it's already May 2024 meeting of the Health and Social Care Committee. Stephen, do we have any apologies?
Just from Jill Mitchell.
Thank you very much, Stephen. And I noticed in the chat that there's a few people attending for other people, which is lovely. Welcome to all of those there. And there's a few people I think going to have to nip in and out with various matters they have to deal with during the meeting. So that's absolutely fine. Just feel free to drop out. So we'll move on to declarations of interest. Does anyone have any matter of interest related to any item on the agenda which they feel they have to declare? I am not seeing any hands, so we will record no declarations of interest. Move on to assurance report from the meeting of the 6th of March. I won't, in my usual fashion, I will not go through that page by page. I will just ask, does anyone have any matters of accuracy that they wish to raise? Nope, I'm not seeing any hands, so we'll accept that as an accurate record of our meeting on the 6th of March. And does anyone have any matters arising which they don't feel we're going to cover in the agenda as we move forward? Neil, I can see your hand.
Hi, Jerry. Yeah, Jerry, it's just a quick thing. Maybe we could cover when we come to the financial report. It's just my personal understanding of what is the quantum as relates to the council and putting monies. I think it's the second paragraph of the assurance report related to financial aspects. Sorry, I'll just see if I can find it here. But Chief Officer noted 20 million put aside to support transformation activity, and then there was a mention of reduction in the quantum. And pardon my ignorance, but I was just wondering what the quantum was. Is that monies that moves from the council to the NHS, or yeah? I kind of figured it might be, and I can see Pamela nodding. But it's just explanation for those of us that don't quite understand the. No,
that's absolutely fine. I think we'll cover that in a bit more detail, I'm sure, in the 24-25. But it is as simple as that. It is the value which the Highland Council hand over to NHS Highland, and we have a quantum which we hand over the other way for children's services. Yeah, probably just a bit of jargon which we just need to watch for in the minutes. Thank you very much for that, Neil. I'm also going to draw members' attention to the work plan for 24-25, which is there. There's been no changes to the work plan for 24-25 as of yet, although I'm sure it will change. I would like to draw your attention to note that Stephen sent out an email, I think earlier in the week. We've provisionally put a couple of dates in for development sessions later in the year. I think July and November. I won't attempt to remember the dates. And what we're probably looking at there, or we're definitely looking at there, is the July event being roundabout strategy. And I know it's a fairly broad heading, but I think that will become a little bit clearer as we move through the reports today, when there is many mentions of we need clearer direction on this, or we need a plan for that. And it's really just a discussion for the committee to see how we can bring all these different strategic intents together, how they all fit together with the approved adult strategic plan, and how we're actually going to do that. And I think that leads us on to later in the year where we're looking to have a discussion about information and quality. What information does the committee need in order to see the delivery of those strategies, and actually how do we measure the quality of those services? There's lots of quality work going on, but I think we've never actually specifically spoken about it here. So I would urge members, if they at all can, to get those dates into their diary. And actually, if you can, just drop me an email with some thoughts. Pam and I will be working over the next few weeks to try and firm that up, but we certainly want it to be a two-way discussion. Oh, sorry.
Okay, just checking that everything's working. Sorry.
Oh, no worries, Michelle. Here. Thank you. Okay, so we will move now on to item 4.1 on our agenda, Blueprint for Good Governance Improvement Plan. And with apologies to members, Ruth has pointed out to me that we have circulated a September update when there has in fact been an update right up to the Easter break, up to about the 15th of April, and we will get that circulated to members, but I'm sure Ruth will pick that up in her comments. Thank you, Ruth.
I will do. Thank you, Jerry. Yeah, sorry, that was my fault. I didn't give the most up-to-date appendix with my report, so it's there in the Teams channel for you to look at just now. So the board agreed its Blueprint Improvement Plan last July, and the Blueprint Improvement Plan has 17 individual actions on it. The Blueprint is the Scottish Government's Blueprint for Good Governance. So the board has assessed itself against the expectations of the Blueprint. It's a guideline, and we've identified 17 different actions. Of those 17 actions, there are 3 of them which are of interest to this committee. So the plan rests with the board to be overseen and determined by the board, but the board last July asked its governance committees to oversee informally some of the progress that's being made against those 17 items on it for the areas that are of particular interest to the individual committees. So you'll see in this report that there's been good progress against the 3 items that are of particular interest to you. And that's in relation to embedding patient and community representation and feedback into our performance framework. So there's an update there in the most up-to-date appendix about the progress with the care opinion pilot and the Highland 100 panel. The next item was about establishing a plan to implement a quality framework, which should arise from the work that was carried out months ago with Amanda Croft. And we're holding some joint sessions with our Area Partnership Forum and our Area Clinical Forum to go through that, so that we're engaging with our clinical and partnership colleagues to build that into the quality framework. And the last one there is to ensure that patient feedback is responded to and that it's fed back into improving services. So this is probably a longer term span for this particular action, and that's ongoing, and there will be a requirement for some considerable work to be undertaken with that, but it's been started and it's certainly been looked at. So as I say, this is a progress update report. To give you an idea of where we are as at April this year. There will be a full report going to the board spanning all of the 17 actions, and that will go to the board at the end of July. So that will be its anniversary. So we'll see the whole year effect. So this report's offering you moderate assurance, just to give you confidence that these actions are all being actively pursued and to reflect that there is ongoing activity. None of these actions will easily be ticked off and completed. So there's a lot of activity required and a lot of engagement required on every single one. And as I say, there'll be a full report on the blueprint going to the board in July. So it's there for your information and your assurance as well. Thank you.
Thank you, Ruth. Anyone with any questions of detail for Ruth that hopefully she can pick up? Diane.
Oh, hello. Just to say that it's really good to see that progress is being made on issues around patient and and community involvement and engagement. I'm really pleased to see that, and would welcome regular updates about where you're up to. Later on in the agenda, there's some information about engagement processes that have been undertaken in other contexts, and I was just going to say that I really welcome those and pleased to see that new methodologies are being used. So great.
Thank you, Diane. I'm not seeing any other hands, so in the interest of time, I will just ask: are the committee happy to note the update, the revised update in the Teams channel? And I accept that we probably had minimal time to look at that, and accept moderate assurance. I'm seeing nods and thumbs, so we will take that. And thank you very much indeed, Ruth.
Thank you. Thank you very much. Okay. Bye bye.
Okay, we will now spend a little bit of time talking about everybody's favourite topic, money and savings challenges and so forth. Probably firstly from me, just apologies that there's been no papers issued to this, but this has not been tardiness on anyone's behalf. This is really just to reflect that really what we've got both in relation to 23-24 close down and getting 24-25 up off the ground. We've probably got a very fluid situation, probably about as fluid as I've come across in my time in the health service. So Elaine is going to take us through 23-24. We'll probably pause on 23-24 just to get so the committee can get a feel for that, and then we'll go on and have a discussion about 24-25. Elaine will give us an update on where the board is overall and the challenges that we look like we're facing, and then Pam will go on to how we might be looking to address those challenges in the health and social care context exclusively. So thank you if everyone's comfortable with that, and I'll hand over to Elaine.
Thanks, Jerry, and we'll get these slides circulated, but as Jerry's mentioning at the moment, got to caveat them that they are still subject to final adjustments and audit scrutiny, so they could change. So where we ended up as a board, this is just showing the progress throughout the year. So the red columns here are where we expected to be when we submitted our financial plan to Scottish Government in March 2023. So we had that 68.7 million gap identified. During quarter one of the 23-24 financial year, we received significant additional funding from Scottish Government, and the expectation was that we would reduce that 68.7 million gap down, and we were tasked with coming in around 56 million. So that's that green trajectory, the green columns that we're seeing here. What we have actually seen at the end of the financial year is an overspend of 29.2 million, so almost 40 million pounds better than we expected at the start of the financial year. Now, whilst we have achieved some savings to bring that position down, what we have also seen is significant funding that's flowed from Scottish Government. We've seen funding for consequentials that have came from the UK Government. We've seen additional new medicines funding, and there's been other elements of additional resource put into the budget as well. So delivery against our initial plan, but delivery against our RRL, so that's our revenue limit, we're 29.2 million overspend. But looking at delivery against a financial plan, we're almost 40 million better than we had expected. And within our cost improvement programme, the cost improvement programme had a target of 29.5 million, and we have slippage against that of 15.9 million. So just looking at how we've got from the initial position, so that 98 million, which was the gap before savings, we've achieved savings of 13.6 million, and we've just listed the additional funding that has come in there. So about £35 million worth of additional funding that has went to support the overall financial position. We've also seen a reduction in some of the top slice costs, so we contribute to national initiatives, and that's come in slightly less than expected. We've also used elements of financial flexibility, which are some technical adjustments that impact on the balance sheet, don't have any impact on service delivery, but we've been able to release £2 million there. And we've also seen some short-term cost reductions and allocation slippage of 18 million. And that 18 million in the main is coming through vacancies. So we've struggled to recruit this year. So we've got a number of vacancies, but what we are seeing is that we're seeing locum and agency cover to come in for that. So that's just where that balance is. looking at the deficit across the operational areas, the partnership is reporting an overspend of 10.6 million, acute services 20.3 million, and support services are actually showing an underspend of 1.7 million. And that's actually where all those additional allocations come in so that we can take that benefit to the bottom line. Argyll and Bute have delivered a break-even position. So Argyll and Bute have the flexibility of being an IGB and can take any underspend to reserves. And similarly, if they were in an overspend position, they can draw down from reserves to cover that. So they are reporting a break-even position at the end of the year. So looking at the partnership in a bit more detail, that £10.6 million is actually all sitting within health. Whilst we had been anticipating a significant overspend within social care, we have managed to bring that into a break-even position by year end. How we've managed that, there's been an adjustment for the purchase of Mains House, which had happened earlier in the financial year. We've seen the benefit of approximately £1 million from previous year's allocations that we weren't expecting to be able to access, that we have managed to access. We had anticipated that we'd be paying about £1.7 million for additional payments to providers, but that's dropped significantly during month 11 and 12, and that was only 1.2 million. So we're seeing the benefit of £500,000 there. And there was a couple of elements of funding that we'd assumed that were ceasing at the end of 22-23, but they've actually continued into 23-24. So whilst we've managed to balance the position for this year, it's unlikely that going forward into 24-25 there'll be any recurring benefit from that. So looking at the locum and agency spend within the partnership, about £24.4 million, and in the main that's due to difficulties that we've got recruiting across a number of different services. So that's the adult social care position, just broken down across the different service categories. I won't go into it in any great detail. So for North Highland communities, we are seeing ongoing pressures within enhanced community services and chronic pain, which have contributed to the overspend, but the services are working to realign the service provision to the funding envelope that's available. So that forms part of the value and efficiency work for 24-25, which I'll speak about when we move on to this financial year. And within that 8.8 million, there's 6.7 million of that relates to adult social care, but we need to rebalance that adult social care budget so that the additional allocations that we've got, and we know that are recurring into 24-25, can drop into this area. Within mental health, we've got an overspend of 6.3 million. And in the main, this is driven by medical locums and agency nursing costs. So they've been covering vacancies throughout the year. And we've also got some out of area costs which have contributed to the learning disabilities provision. And that's an area that's being reviewed at the moment as well. In primary care, it's quite a similar position to mental health services. Medical locums are being the main driver within that, and within our own 2C practices where we've struggled to recruit GPs. Within the GPS, so that's the prescribing line, we overspend there is due to an increase in the number of scripts that have been issued, but also the cost of drugs has increased significantly as well. And that's something that's been reflected across the country. It's not something that's just local to NHS Highland. There's been a number of vacancies within the dental service, and these have continued throughout the year, which has resulted in an underspend within that area. So just a summary of the cost improvement programme and how that ended up at the end of the year. So the £29.5 million target. At the end of the year, we had slippage of almost 16 million, which meant we delivered £13.5 million worth of cost reductions and cost improvements throughout the year. And that, that breakdown at the bottom table shows that the partnership had generated £3.8 million of efficiencies. That's the summary of 23-24, so I'll stop sharing just now and happy to take questions, and then we can come back to the final couple of slides that I've got.
Thank you very much, Elaine. There was a lot in there, and it'll be nice if you could circulate those slides as you promised, obviously with the caveat that they're all subject to conclusion of the year-end audit, which, if memory serves, is probably just about to commence this week. So, I mean, maybe about I'll let colleagues gather their thoughts. I mean, so I think we finished the year end as a partnership better than we had anticipated, but I think we could characterise that as an unexpected place rather than where we fully expected to be. And I think we've got a bit of work to do, and Elaine and I and Pam have had this conversation just in terms of just understanding, although it was a nice surprise. The best sort of surprises are no surprises as you move into the year end. So we've really got a little bit to understand there. But I think the key messages for me to colleagues would be that those benefits we've picked up in 3.4 are undoubtedly non-recurring in nature, and we've still got some really big issues moving forward there in terms of. And if you just look at it, if you just look at the numbers, I think we've got some big issues there in relation to mental health levels of spend, prescribing levels of spend, and probably for other reasons, we've got big issues there in relation to GDS spend, because we've got a big underspend there, which we would not want. And actually, we've had discussions there before about the detrimental impact that's having on services. And actually, from a service point of view, we would much rather that money was getting spent. Just as an aside, Elaine, and I'll finish up there. The 29.2, I'm assuming now, and I don't want to get into technical jargon, the board have now applied for brokerage to the Scottish Government to cover that shortfall for 23-24 for the preparation of the financial statements.
Yeah, following the Financial Resolution Performance Committee on Friday, a formal request is currently in the process of being sent to Scottish Government requesting brokerage of 29.5 million to allow us to deliver a break-even balance position at the end of the financial year. So we're expecting that to come through in an allocation later within the next few days.
Okay, thank you very much for that, Elaine. I'll be quiet now, and I'll let colleagues come in. Muriel and then Anne.
Thank you. Thanks for the report. I think just following on what Jerry was saying there's a couple of concerns, big concerns, because there was some revenue additionality that was unexpected, and we're not going to have that. And we know that our demand is not going to lessen. We've got services to provide that we're struggling. So we need to, how are we going to pull this all together? And I don't think we can wait a year to get a financial update. I think we need to do this more often and see where we are with our services. I'm concerned about potential waste. We talk about the increase, we all know about the increase in pharmacy charges, but the scripts, the increase in scripts, is there any modelling or work going on round about that as to, could we be looking at why is this happening? Is it because they can't see staff members, whether it be it GPs or Pharmacy First or whoever it is, would our clients benefit from enablement, which we talk a lot about enablement, but what are we actually doing about it to minimise some of these other financial challenges? So I'll stop there, but there's a lot around this that we need to keep on top of.
Elaine, I'll maybe ask Anne to come in, and then you can pick everything up in one fell swoop, hopefully. Thank you.
Okay. Thanks, Jerry. So it was just a couple of clarifications, Elaine. In terms of the savings that were achieved, what percentage of them are going to bring recurring benefit? And then secondly, in relation to allocation slippage, it was clarified for me recently that was largely as a result of services that we receive allocations for, but we have long-standing difficulties recruiting to, and pretty much know at the start of the year that we're not going to be able to fully use those allocations, rather than us deciding to take any allocations to our bottom line. So I just wondered if I could ask Elaine or Pam, what, if any, of those situations are within communities' health or social care side of things, or do they relate more to the acute sector? Thanks.
Thank you, Anne. Elaine, I'll let you come in, and then maybe Pam, you can follow up if there's anything you think you want to add. Thank you.
Okay, so just following on from Muriel's points first, so just a bit about reporting. We'll bring a report back to each meeting of the committee. I think once we've got 24-25 input into the ledger and we've got the more detail around our cost reduction, cost improvement programme, we'll bring back quite a bit of detail around the individual elements of the programme. And just linking into that, prescribing is quite a significant part of our value and efficiency work this year. So we've got 3 prescribing work streams looking at the acute sector, community pharmacies, and also prescribing within our primary care area. So that will be picked up and we can bring back the detail and what work's ongoing within them to a future meeting. So, and the savings, the recurring split, it's actually only about the recurring element's only about 20% this year. So it's not as significant as we've seen in the past. I think initially when we were in that cost improvement, cost reduction phase, probably pre-COVID, we were looking at about 70-80% being recurring. Unfortunately, when we do generate non-recurring savings, we do have to actually carry that forward into the next financial year. So whilst we see an in-year benefit from it, we don't see any longer term benefit. And the programmes of work that we're trying to develop at the moment are definitely focusing on getting the recurring benefit out of those reductions. On the allocation slippage within 23-24, that has been fortuitous. It's not something that we've planned at the start of the year. We always know that there are allocations that come in partway through the year that we perhaps are full year funding. So we know that there's always an element of slippage, but we don't necessarily know in which allocation that slippage is going to be against. So this year we haven't taken any conscious decision to pull back on spend. There was a few requests for spend towards the end of the financial year where we knew that we wouldn't be able to deliver the goods or services prior to the 31st of March. And by allowing those to continue, it would have created a pressure into 24-25. So those are the types of ones where we have consciously held back on spend against allocations. I hope that gives a bit of clarity, but if there's any follow-up.
Thank you, Elaine. Pam, anything you want to add to that? Are you content with what Elaine has briefed the committee on?
Yes, I'm content with Elaine's update. Thank you.
Okay, thank you, colleagues. I'm not seeing any other hands up, and I think, and given that there's still probably a fair amount of work to be done on the 23-24 position, I suspect Elaine would just be gathering up questions to take them away. So I'm going to propose that we allow Elaine to move on to 24-25, but maybe if we just pause before we go on to 24-25 and say, accepting that it's been a presentation and a discussion, are we content to accept limited assurance on the 23-24 financial position? I think that's where we are as a board as well. So thank you very much for that, colleagues. And we will now move on to 24-25, which I'll maybe let Elaine set the scene, and then Pam will take over. Thank you very much.
I've got a couple of slides and then I'll pass over to Pam. So this first slide here is just showing the estimate for adult social care for 24-25, and I'm not sure if Neil's still on the call, but we mentioned the quantum again, and that is the funding that transfers over from Highland Council to NHS Highland. A lot of that's coming in through direct allocations from Scottish Government to Highland Council, and they're then passed directly through. So we've got an estimated expenditure of 188 million against funding at the moment of 164 million. So we've got a gap of 23.4 million, which is taken forward as part of the overall NHS Highland financial plan. So this slide's just summarising what's in the financial plan and the challenge that we've got for 24-25. So we've got an initial gap of 112 million, just shy of 112.5 million pounds. We know that Scottish Government are prepared to give us brokerage up to a maximum of 20.4 million. 24-25 is actually a very challenging year for Scottish Government because almost all of the territorial boards are in a position where they are actually seeking brokerage from Scottish Government, whereas in the past there's maybe only been 2 or 3. So we don't have the level of flexibility there that perhaps we've had in the past. So that leaves us with £84 million to identify where we can actually to balance the budget in year. What we've looked at is the value and efficiency scheme. So we've broken it down in a number of areas. We've looked at value and efficiency, and we've looked at elements of choices and those things that are perhaps longer term and would take a bit of support from Scottish Government and a bit of community engagement. So the value and efficiency, this is actually a target that Scottish Government are saying that we should be achieving year on year, so a 3% recurring reduction in our cost base. So that's approximately 21.7 million. Argyll and Bute, because they sit slightly separately as that IJB, they have been challenged to deliver a balanced position. So they're looking at having to identify cost reductions and improvements of 6.2 million. And the adult social care, we've got the gap of just over 23 million. So when you look at the adult social care, if you take a 3% value and efficiency target there, that's 5.6 million, which leaves the balance of that really to come through like transformational activity and how we deliver adult social care services. So in total, the value and efficiency taken into account the adult social care savings would generate £51 million. What we've then looked at are the more difficult to implement schemes and transformation areas. So within Argyll and Bute, a further 2.7 million to be generated, and within North Highland, 30 million. And that would give us the potential opportunities of 84 million. So it's amazing how easily 84 million trips off the tongue as being the challenge that we've got to achieve, but there's an awful lot of work going on in the background around the schemes that we can develop to deliver that. We're in ongoing dialogue with Scottish Government around what would be acceptable for our financial plan for 24-25, because at this point in time, it's not actually been signed off by Scottish Government. They are expecting further iterations of that. So we will bring more detail back to each meeting of the committee and just set out the individual elements of the cost improvement, cost reduction programme, but also what challenges we're facing with some of the choices work as well. So happy to take any questions, but we'll definitely bring detail back to the next meeting.
Thank you, Elaine. I'll give colleagues the opportunity to ask any questions on the numbers of you. But as we relate to the partnership, given that we're in the Health and Social Care Committee this afternoon, as we relate to the partnership, would it be fair to characterise our challenge within Health and Social Care has been to deliver our share of the 3%, whatever that is going to be, and I've not been able to do the numbers off the top of my head, plus deliver a balanced adult social care position, and we'll park the remaining gap at the moment, because that's obviously still subject to discussion with Scottish Government in terms of how that may or may not be treated in year. But would those be the two main challenges for us in that health and care sphere as we sit here today, Elaine?
Yeah, they would be, Jerry. And I think the 3% target is what we're working towards. We've not actually split it down across operational areas. We've looked more at the functional areas, so prescribing and how that fits in, taking into account the elements of locums and agency nursing as well. So those are the type of things that are falling within that value and efficiency sphere at the moment.
Thank you very much. So just in terms of that context, colleagues, does anyone have any questions they want to ask of Elaine, just to clear up and just get an understanding of where we are at the moment? David.
Yeah, thanks. When I look at the adult social care strategy, which is about delivering savings as well, that is, as I understand it, partly about changing the balance of care. So we've got fewer people going into homes, able to support people in the communities more, and things like that. I was contacted yesterday by one of the handy person services, and I'm told that Lochaber Care and Repair have been told that their fees to them will be reinstated to 2015 levels. Now, you know, care and repair do such a valuable job in helping to get people out of their homes, help with independent and everything else. I mean, I haven't looked, I don't know what the exact figures are, but a quick check on the Bank of England, that would be effectively, you know, 2015 levels, 33% inflation has occurred since then. You know, so if we're serious about the change in the balance of care, we need to be investing in our community services. So I don't know if this is correct that we're cutting handy person services by, you know, back to 2015 levels. Sounds way above the 3% that target. It just doesn't feel right at all, and I don't know where that's come from. But I would ask that there's a review. It's kind of it goes beyond this committee, but could somebody look into that and check what's happening and get back to us? I see Pam's put her hand up. Thanks.
Pam, do you want to pick that one up?
Yes,
Either
I'm
now or
happy.
get back to Councillor Fraser outside of the meeting.
Yes, I can come back to you out with the meeting. I have met with Fiona Davies, our new Chief Executive, last week around their funding, and we have agreed to provide a response to them by Friday this week so that they can take that to their board around ongoing funding. So I can furnish you with that detail. Councillor Fraser, and also we are working jointly with the Highland Council to procure and put a new handy person service in place so that we can get to a more equitable financial balance going forward, and with our contract monitoring. So I'll furnish you with the figures out with the meeting. Thanks.
Thank you, Pam. I've got Anne and then I've got Diane. Again, if we'll take both of you one after the other and build up a head of steam.
So, Jerry, I think Councillor Fraser's question there well illustrates the challenge that is facing this committee and also the partnership, in that we have a strategy which is based on shifting the balance of care into our communities, yet for a long time we have not been able to invest in the community supports and services that would help us move towards that strategy. So I think that, you know, there's obviously a very particular issue here, but setting that aside, throughout today's agenda, for example, the self-directed support paper refers to community hubs and community-led support. There are many organisations, I'm sure, that are providing services in the community that have not been able to receive an increase from us for some time, to say nothing of the additional services that many of them would like to develop. And it's a real challenge that we have to, I think, work in partnership with these services and with the council to try and ensure that we can draw on other sources of funding and support and have a more long-term strategic relationship with these organisations that is understood by everybody about what it is possible and is not possible for the partnership to do. So I think David's question well illustrates the challenge that is facing us in the year ahead. If I could come to my specific question rather than my comments, could you just clarify, Elaine, for us whether the figures that you put up there, the quantum and the gap, include the 7 million that the council have agreed to reduce the quantum by, or is that still to be added into those figures? Thank you.
Diane, do you want to ask a question, and then we'll let Elaine come in and pick them all up?
Yes, thank you, Jerry. My question is really mostly about process, and it highlights the point David's made, actually, which is that thank you for the overview of the figures, and we fully recognise that a lot more work needs to be done in order to finalise those. My concern is that I think that this committee needs to receive a lot more detail about what is proposed in terms of savings, particularly in areas that are the remit of this committee. And without such detail, I think it's difficult for us to give assurance to the board. So my request is to say, when will we receive detailed information about what savings are being proposed?
Thank you, Diane. I'll remit that question, if I may, to Pam, and ask that she addresses it as she goes through her couple of slides as well, in terms of exactly what the process is and when we might have that appropriate level of detail. But I'll maybe pass back to Elaine with the question on the value of the quantum, and if we could come up with a better name for quantum, that would be lovely.
Yeah, the 23 million does include the £7 million reduction that we've been notified of.
Thank you very much, Elaine. I'm not seeing any other questions, so I'm maybe going to pass over to Pam now, who's going to take us through a high-level process review and where we are. But she will, I'm sure she will, because I've had the discussion with Pam in terms of how we will actually start to build up the level of detail that we're actually, which will actually allow us to actually deliver on our severe financial challenges, but actually provide that assurance to the board as well. Thank you very much, Pam.
Thank you. So, just in terms of the value and efficiency work, so across health and social care, then we are engaged in the value and efficiency work. A lot of the work streams we've already discussed around, prescribing and, reducing our reliance on agency and locum staff, both across medical and nursing and midwifery and AHP. Pharmacotherapy, the pharmacy, the prescribing, and how we manage, pharmacy delivery is a big area, a big piece of work. And of course, we've already mentioned the chronic pain service. We're also looking at, the cost of packages that we have out of area. And whether they'll be, more efficient to bring them back to Highland. We've also got our overarching charters that describe our services and where we need to make changes. The potential changes and choices that we have in line with our joint strategic plan implementation, so that local interface with our locality planning, with our district planning groups, with our community planning partnerships. There's a lot of work to be done around engagement with our community, around service provision going forward, what's needed and what that shapes and looks like. And we've also been developing an overall commissioning strategy and a primary care strategy that augments that as well. Have my slides gone on to slideshow? Can people see them? You just give me a yes or a no. Yes, thumbs up from Jerry, thank you. So in terms of the adult social care cost improvements then for that big 24.2 or 0.4 million figure, there is a process at the moment where we've identified cost improvements and efficiencies. That has been drafted, and we're in the middle of costing that. So across the organisations, we're putting the financial plan around that, and both chief executives are working at a senior level, to agree what that looks like and think about how we prioritise and sequence some of the work that will give us some of that cost improvement going forward. And also the Highland Council have a 20 million transformation fund that they will support us with, delivering on some of those cost improvements. So, we've got, work that we want to do, which I'll come on to, but we've also got actions and enablers in areas where we may seek to deliver transformational change over the next 2 to 3 years, in line with our value and efficiency programmes and our choices as well. and the implementation of the joint strategic plan. So it does all come together, and recognising what we need to do is to bring the detail and the financial detail back to the committee in the future. But at the moment, in terms of developing our adult social care cost improvement plan, then I just wanted to give you some headlines and the process by which we've gone through. So we've done a lot of information gathering, from our in-house services, working with our partners and the independent and third sector providers as well. And we've done quite a bit of data analysis around, what services cost, where we provide them, how people receive their services, etc. So we've got quite a lot of modelling and assumptions that we've been undertaking, and we've got some actions and enablers. Key to that is the experience of our partners. We're very, very heavily based on providing in-house care, which is very expensive for the statutory sector to provide. So we're working hard with providers to try and change that model so that we don't end up in competition for the scarce workforce availability that there is within Highland. So some of the key actions that we want to take as a result of the modelling and the understanding of how services are delivered against our financial envelope, then we need to reduce our in-house provision of care home and care at home services. We've done the modelling. It clearly shows that to provide it in-house is twice the cost of the independent sector, and that has seen attrition from the independent and third sector and applications for jobs into the NHS, where the wages are higher and the terms and conditions. So we need to take an action to disinvest from our in-house provision as a priority, and we need to do that in partnership with our sector partners, to enable them to have the opportunity to recruit and sustain, services, and we need to sustain our partners and providers in Highland. So we've developed a number of commissioning proposals to improve care at home capacity and flow, and of course we're well versed. We'll come on to the IPQR later on, and we'll look again at the data, and not much traction and change in terms of flow. So we've done a lot of work to analyse the care packages and the cost base of those, again recognising we need to reduce the in-house provision. We want to slow down recruitment to NHS Highland provision, and we want to stop the competition then that's been created with the independent and the third sector workforce just around our terms and conditions, etc. So if we slow down our recruitment, then hopefully that will open up the employment opportunities in the other sectors. We also want to deliver on the value and efficiency work streams, which I've mentioned, which is reducing our agency staff. We also want to reduce length of stay. So, working with our joint strategic plan, home is best, all of the opportunities that we have to us, to prevent and reduce the time that people are delayed in hospital, delivering across all of our urgent and unscheduled care work streams. And of course, we also in tandem want to develop a trajectory for the workforce development outcomes so that we can see when we're sequencing new roles or we're looking at employment markets or people who are in training who are going to qualify with different skills and different qualifications to come into health and care careers, then we want to develop a trajectory so that we can sequence that in terms of our intentions to implement our joint strategic plan. We've got a number of enablers in place as well, which are the underpinning key pieces of work. So we've got a care programme board in place to oversee the forward planning and sustainability of the independent care home sector, and we're engaged in partners, and you'll hear much more about some of the engagement and the outputs that we've had when we present that paper later on in the agenda. The sector engagement is really important on the cost modelling, and we need to agree and co-produce aims that we're going to deliver on. So, that's part of our commissioning strategy. We need to develop an overall improvement plan. So we're halfway through developing that. We have to cost it. And as I say, that's sitting with both chief executives at the moment. And of course, we have a number of fora that may need to go through in terms of the NHS board or the Highland Council or the Joint Monitoring Committee as well. Technology-enabled care offers us a number of solutions, and that enables us to optimise housing options. So getting people at home, thinking about telecare, thinking about the technology and developments that can help people get home quicker and can enable them to be at home with all sorts of different technology and apparatus that will support them. And of course, we've done quite a lot of work around our integrated service planning. We understand much more about our workforce, about our service delivery, where we're delivering services, really underpinning that choices work. And of course, having more data at hand when we go out to communities and we discuss with them about what their service looks like, what their service currently costs, discussing with the community how we can deliver things in a different way, in a more efficient way, and looking for ideas from the community as well about how we can do things different to deliver their care closer to home and deliver on the aspirations that we've set out in the Joint Strategic Plan. So that's quite a lot. So I'll stop there and I'm happy to take any questions. Thank you, Chair.
Thank you, Pam. Very, very simple slides, but a whole host of work actually in order to deliver meaningful service transformation behind those. So I'll throw open to colleagues and we'll maybe collect a few comments just to allow you to gather some thoughts. So I've got Muriel, then Diane, and then Kay. Thank you.
Thank you, Pam. We've been to many meetings over the years and talking about the Fit Home and the technology-enabled care. What sort of progress have we made? I mean, many of us have been to Invergordon. There was talk about Ullapool recently, but what does the expansion programme look like, or is it still the same settings that we're providing? Have we sort of stalled?
Well, we do have a whole lot of new suite of technology-enabled care products. So we are able to work more with families around choices and enablement to get people home. And as part of our value and efficiency work, then technology-enabled care is a very big piece of work that we want to and need to deliver on. And we are in the process of fully costing that, and we'll be able to articulate what the benefits are of being more efficient with technology as we go forward. And that's not just something for us to deliver in-house, across all of our partners, across the handy person services, in partnership with the Highland Council and Housing as we're developing housing. So we need to articulate that much more robustly within our housing strategy that supports the implementation of our Joint Strategic Plan. So there will be reports coming back to committee at regular intervals around how we're developing those services and how we're benefiting from technology, and also an update about what the new technology is in terms of falls prevention, in terms of pharmacy, in terms of telecare, telemedicine, all sorts of different products. And it might be beneficial to bring a more detailed report back to the committee at some point on those specifics.
Thank you, Pam. Diane.
Thank you for that, Pam. I completely agree that we need to take a very radical and transformational approach to dealing with the challenges that we're facing. My concern is that if we're pausing recruitment or reducing our own input into care homes and provision of care, that it will presumably put some care homes at risk of closure. And if that is the case, how are we going to handle the community fallout from those decisions?
I mean, it's our intention, it's an aim, looking at we need to create more sustainability. within the independent and the third sector. One of the destabilising aspects has been, the attrition from the sector into the NHS, in terms of staff movements. So what we want to do is work jointly with the sector to rebalance that. So we've not made any direct plans to do anything at the moment, and we're certainly not going to be stopping recruitment anytime soon, because we've got to sustain our in-house services. What we need to do is jointly co-produce a plan that we sign up to as partners through that commissioning and collaborative commissioning relationships, so that we can jointly meet the aims that we're trying to achieve. So there's no intention to say next week, well, we're just going to stop recruiting so that the independent and third sector can take up the posts. There's workforce challenges across all of our workforce groups across health and social care, and I don't think just slowing down recruitment will help our partners. We need to actually work together to agree sustainable solutions that we can test in terms of test and change over the next year as we try and deliver this cost improvement plan and efficient ways of working.
Okay, I just think we need to handle that very carefully, because
absolutely,
communities get very agitated at any suggestion that their facilities may be closed or removed. And I think if we do intend that, can I just ask that we're honest and open with communities about any such plans, and that therefore, we're being transparent?
Absolutely, and we will be using our engagement framework when we're out working with communities, and make sure that we've got all of that elements of good and open engagement, and co-production of the plans and services that we want locally, and that's where we're trying to get to.
Okay, thank you for that assurance.
Thank you, Diane. Kay.
Yeah, Pam, I'm glad to hear you're not pausing recruitment straight away, because there's a lot of staff that are running around the areas because they're short-staffed already, and they might sort of just up and leave if they weren't out anymore.
No, nothing like that.
Yes, but I think the cost difference between the private sector and the NHS, I have a worry that because the private sector, if you think of care at home or care homes, they tend then to operate in higher density areas where the model is profitable and cheaper, and anything that's not profitable they hand back to the NHS straight away, in areas. If they try something and it doesn't make a profit, right, oh well, the NHS can have it back again because we're not doing it. So therefore, as far as the model's concerned, the NHS side of things is going to be more expensive because of the area they work in. I get regular phone calls from care at home workers who love the job, absolutely love the job, love what they're doing, but I was just wondering if they can afford to do it anymore because of the amount of miles that they do. And, they don't really get access to a pool car unless it's over 3,000 miles. They can sometimes get access to a pool car, but pool cars aren't, as accessible as what they need to be. That's a big issue for staff. And some of the private companies, they will employ people who don't need a car and don't need a driving license. So therefore, their take-home pay, in actual fact, if they're not having to pay the expense of having a car, is not as expensive as some of the NHS workers. So that can make a big difference.
No, thank you, Kay, for bringing up the staff experience of the sort of wider economic challenges that and workforce recruitment challenges that we're all exposed to. And I've done a lot of work with private providers. They don't give up their services easily in terms of a profit envelope. There are wider economic challenges. They're very, very people focused in terms of the services that they provide. Often it's to do with challenges in affordability and sustainability of the smaller size care homes, you know, and just, you know, looking at how they can manage that going forward. And we've had really good engagement from the sector, who have given us early indication that they're not coping, and we've worked with them to support them with sustainability payments, to help them with their business plan, to help them with workforce developments, and again try and co-produce things. So you know, I'm not seeing it very much being a profit only lens. I'm seeing a lot of co-production across the sector, which is really positive, and I think that gives us a good platform for going forward. You know, co-producing some of our ideas through our commissioning framework, and changing the model to sector sustainability. And I think there is a commitment to work in that. We're all jointly partners trying to deliver health and care services in Highland. So the more we collaborate, the better outcomes that we'll have for people. Thanks, Kay.
Thank you, Pam. I've got David and then Anne.
Thanks very much again. Two different topics here, but just on the care and working with the third sector, absolutely welcome that, Pam. One of our biggest challenges is when we get care homes closing unexpected, short notice, and that can have devastating impacts on the people and on the community. And part of the solution going forward is very much about working with our good third sector people, and helping them to see. Apologies, there's too many phones in here. Helping them to understand the journey that we're going on, and how that shift of balance of care that we talked about earlier, how, you know, where our needs are going to be, and that way they can also invest with confidence, and that we end up all in the same journey. So sharing our vision, finding out what works, and listening, that's great news. On the digital side of life, I presume, sorry, we're talking about telecare and different things. I presume we are talking digital rather than analog. I take it up every time I can, so I'll take it up again about this analog switch off next year. And that really still frightens me. And the risks associated with relying on digital technology when there are power cuts, which can last for a long time in our remote and rural areas. And from what I've seen of the backups currently being proposed, they just don't seem to be adequate. So clearly there's going to have to be a whole lot of work around that risk. I think it's absolutely the way to go. It's to be recognised and managed, not avoided. So I'm fully happy with the strategy, but let's make sure that we're there. But really frightening the timescales. Thanks.
Thanks, Councillor. Yes, it does. It does actually bring us a lot of challenges and a lot of fears about the unknown. And you know, what I guess we have to rely on is, you know, we've had several incidents over the winter where we've had to stand up our incident responses to storms, and you know, people being cut off of electricity and all sorts of other care for people that we've had to respond to. So, you know, across our agencies, across our multi-agencies, then we are able to stand up and respond, and we've tested that you know, we are good at doing that, and there's always areas for improvement, and we're learning all the time. So when we do switch over from analog to digital, you know, we can rely on some of those systems if you know, the digital fails for any reason because of, you know, power cuts or other infrastructure failures at any time. And it's about having those those risks understood, and about having those multi-agency plans in place, you know, across all of our partners, so that we can stand up and respond when we need to. But it's a good question, and it's always in the back of our minds, isn't it? About the, you know, the inevitable and the unknown. Thank you.
Thank you very much, Pam. I've got Anne, and then I've got Kay, and then in the interest of time, I'm going to maybe try and draw this one to a conclusion, because I think we could probably have this excellent chat for the rest of the afternoon. So maybe Anne and then Kay.
So first of all, just a couple of comments arising from some of the discussion that we've had, Pam. I think it would be, obviously this is very early stages, and as we go forward, clearly we might need to think about rephrasing some of this. I think we're not really talking about slowing down recruitment to our services. We're talking about trying to transfer provision of in-house services to other sectors, really, aren't we? I suspect that's what we're really talking about there. But also, I think it would be helpful, certainly for the non-exec directors, to be clarified whether for the adult social care side of things we are using the same sort of terminology as we're using for the Health Board's overall approach to its financial challenge. So in terms of thinking about the value and efficiency programme for the 3%, the choices programme for the redesign and transformation, I wasn't too sure whether all of those elements were encompassed by this approach or just one of them. But I mean, it may be we have to talk about it differently from an adult social care programme perspective. I don't know, but it would be really helpful if you could have a think about that for the next time we come to this, and just let us know, you know, are we looking at this through the same prism, or are we using a different kind of prism because we're in partnership mode here? But so that, I think I would find both of those things helpful. But I suppose following on from that, my question really was, in the strategy, we acknowledged that the scale of the financial challenge and also some of the emergency situations we are presented with, such as care home closures, unexpected care home closures, might mean that we have to deal with some challenges in the short term, not in line with our longer term approach. So I just wondered if you could clarify whether you think there is anything within your approach to this cost improvement programme that will mean that we will be invoking that caveat in the strategy and having to do something as a short-term measure that perhaps is not in line with how we would want to be moving in the longer term. Thanks.
Thanks, Anne. Yes, and we have experienced that with you know, short-term or shorter term than planned care home closures. So as a result of previous experience, you know, we've set up a care board that you know, has good governance wrapped around it and decision making, real good alignment and processes in place for a kind of standard care home closure, which would be over a 13-week period to get all of the engagement and things. And more recently, we did have to provide a very fast decision making around the responses to Quayle Hall care homes. So we undertook then very quickly, relying on some of the systems that we developed for the longer term 13-week closures within the care home. We have got the care programme board in place. We are working with the sector around our overall strategy. Our commissioning and our marketing framework are going to be really key to delivering on those and trying to sequence and prioritise where we may anticipate changes and where we may have to take decisions quickly. But at that stage, it still involves a lot of community engagement and real engagement across both of our organisations and with our wider sector, so that we're seen to be taking those if they are to be emergency decisions and quick decisions, that we're seen to be taking them in partnership and not just striking out as an organisation in terms of our own decision making. So a lot of it needs to be cultivated going forward in terms of our engagement and relationships.
Thank you, Pam. Kay, I see your hand has went down. Have you? Thank you very much, Kate. So I mean, I thank you very much for Pam for your presentation and and picking up the questions there. I think we, as I say, we could continue with this all afternoon. I think the key points for me is hopefully when we come back into our July meeting, and maybe outside of the meeting, but certainly to the July meeting, once the board has had an opportunity to discuss it, it's May board meeting, that we actually can get presented actually with some detail, I think, as Diane has said, in terms of what we're going to do, when we're going to be doing, and hopefully what the result is we're anticipating out of that, and how we've measured the impact and how we've engaged to arrive at that process. But I know you're clear on that. So I think we will. We're not actually been asked to. We've been asked to note the. When asked to note the savings plan, but I think we would say we don't actually have a plan at the moment. I think we would note the work that is underway in anticipation that we will have something that comes towards a plan when we come back together in July. Are we content with that, colleagues? Thank you very much indeed. So we will move on to a performance and service delivery aspect of the agenda, and these items are fairly linked together and get some common themes. But I'll ask Ian Thompson to take us through the self-directed support strategy assurance report for the year we have just completed. Thank you, Ian.
Thanks, Jerry. Okay, so the paper provided, I think, in effect, gives you an update on the work that we are doing to try to implement some changes in the approach that we take to self-directed support. The situation and background. The introduction, I guess, reminds us of the original ethos of STS, what it was that the government were intending to do, and it sets out what we did in terms of the genesis of the STS strategy. At that point in time, we had done quite a significant consultation of people who were affected by STS, those who worked in the system, but those who received STS, and heard what their concerns were. And it also sets out around about the approach that we wanted to take in terms of change in respect of STS, because that effectively was really trying to set out a culture change from the bottom up. So we determined that how we did it was as important as what we were trying to do to some extent. And really, the rest of the paper then gives you a breakdown, an assessment of the areas where we are trying to deploy that approach, where we are trying to deploy a bottom-up approach and to try to make changes in the system for the people who work in it and those who are recipients of services from it, in terms of their priorities and how they think things need to change. So I shan't go through it in great detail, but I'll just alight on a couple of the areas that I think are important and that are covered in the report. First area is around about the work that we have done to try to self-evaluate where we are in terms of our delivery of self-directed support and take some practical improvement steps to make the way that we work different. That's been quite interesting. That's part of a national work in one of the STS improvement work streams. So we're working with Social Work Scotland, and we're also working with the iHub there. And what we've done is that we've engaged people sitting across the system to try to understand what their priorities are and how they think that we'll deliver more person-centred services. And what they're telling us really is that we need to be have more trust in the system, have a better relationship-based approach to work, and streamline our bureaucratic processes. So a number of initiatives there in terms of promoting worker autonomy, which is in line with the STS standards, thinking about eligibility rather than a kind of threshold for service, but rather one where people will be eligible for advice and assistance across the service and at the first point of contact, and also thinking about place-based commissioning and how we might try to create that kind of network of community supports that people talk a lot about, but actually what does that mean and what would that feel like? We've also been working really with a range of different people in Lochaber to find out what their priorities are, trying to get a bit of intelligence in the system, understand where people's real challenges are, and what they tell us. Yes, it's to do with the social care workforce, but it's also to do with personal assistance and trying to tailor our offer of working in social care. So it's not just a blanket approach, but it really pulls in people to use the different types of abilities they've got. We also would like to grow independent support. So you were talking about the third sector. It's around about matching up all the different kind of areas and resources that are in community, and we think independent support could be really good at doing that. And another comment that was made earlier was around about using our third sector and financing our third sector. Actually, STS could be a route to financing our third sector through a much broader option 2 offer, where people could use their adult social care funding to access third sector resources. So we're trying to broaden our option 2 offer and trying to make it much wider than it currently is, to bring in many more potential providers. And finally, the one I'll light on lastly is the work that we've been doing in West Lochaber with Urim. Some really interesting work there in places where there are very little services, and actually care at home is really stretched. So they try to drive, someone was talking about driving, the care at home workers will drive miles and miles and miles between calls. And what we would like to do there is really to change the focus and have an experiment using STS and all its options, but to try to build neighbourhood care. So build care up from a small community, understanding who lives within it and who can provide support. So rather than us as big systems trying to offer support from a distance, really try to use the intelligence that sits within a community and the legislation that option 1 has to develop a different model of care. So thinking that's really exciting, and one that we're really wanting to pursue. Interestingly, what we did in terms of the engagement in West Lochaber was simply to go to local community halls when there was lunch clubs on and sit for a number of hours, and people would come in and we had a chat, and people told us what they were concerned about, what they thought might work. And I'm pretty certain if you've been over to Loch Allen that you'll know that probably the solutions to Loch Allen's care lie in Loch Allen, because there's a huge big hill between it and the rest of the world, and it seems to not make sense to have carers driving in and out of that, rather than we would situate it there. So anyway, I'm waffling now, sorry Jerry. Just a kind of introduction to the work that we continue to do around a bit STS and to try to change that culture of care.
Thank you, Ian. It doesn't seem like 12 months ago we were discussing this topic, but there we are. I'm going to throw it straight open to colleagues for any questions, comments, observations. If we can take the opportunity maybe to have a short but meaningful conversation with Ian, just in addition to what he's provided in the paper. Diane.
I just wanted to reiterate that I thought this was such an excellent piece of work, Ian. Thank you for sharing it with us. The methodologies that you've used for engagement, for example, are really good role models for the sort of engagement we need to do on other issues. So I just wanted to compliment you on the work that you've done.
Thank you very much. We've had the help, Diane, of quite a few others. So we've had the help from Connecting Carers and In Control Scotland, who have kind of pointed us to, just start small, listen to people. Don't you don't need to impose a big kind of consultation exercise. It's better just to go to where people are at and hear what they've got to say.
I think that's the key thing, isn't it? Go to where people are, don't expect them to come to us, and to use, lots of different ways to engage with people. So thank you for that.
Well, thank you.
Thank you, Diane. I've got Anne.
So likewise, Jerry, I think, it's always good to be able to have an item on our agenda which is about quality and outcomes rather than the challenges of sustainability, although they are obviously related. So I was just wondering if you could expand on something that's referred to in the paper, Ian. At one point, it talks about testing a different model of eligibility. Could you tell us what all that's about, please?
Okay, I'll try not to be too much of an anorak. At the moment, we have in social work desktop, so people come in, they tell us the needs that they have, and generally there's a kind of waiting, there's a kind of triage process where people are often asked to wait because they're not seen to be in very high level of need, and the opportunity to get assessed is much further down the road. What we would like to try to do, and we will try to test it, is to turn that on its head and actually give you some really good high quality social work when you first get in touch with us. So we'll make no decisions around about to what extent you're eligible for service, but what we would say is that everyone is eligible for advice and guidance, and you would get the opportunity to talk to social work, to hear what to be able to explain what your situation is to them, and then get guidance right off the bat. Now, that doesn't cure all our problems because there's lots of different challenges with services, but if we can get social workers really well linked into understanding the resources that are available to people, we know services are stretched, we know care at home stretched, but there are also other helping component parts within communities, and to have social workers genned up in that to be able to give you really good advice around about how you might be able to help yourself, why you might be able to get personal assistance or just private assistance, range of advice off the bat, rather than sitting on a desktop waiting for an assessment that might come along a year later to find out that, well, you're not eligible for services that you didn't quite know what they were in the first instance. So it's really around about trying to put that intelligence, that skill and that knowledge at the disposal of people when they first get in touch with us. I'm not suggesting that there's not a bit of advice given out, there is, but we don't do it determinedly or with that focus, and I think that that's really trying to turn it on its head a little bit. Am I explaining that? That might be a lot of jargon in there. I can't help myself sometimes.
You okay with that, Anne? I've got Kay.
Yeah, I'm interested in you trying to get other people involved that maybe, you know, in the community or whatever. But as far as professional carers or whatever, there's really just one group of staff, if that makes sense. You know, there's one group of people who want to do that for a profession. So if you're using them for self-directed support, it means they're not working for care at home, or they're not working in the care home. You know, I know people who do all three of those things, you know, but when they're doing SDS package on a Friday, they're not working at the substantive job. They're only working 4 days at their substantive job because they're doing SDS package on a Friday. Do you know what I mean? It's
yeah and nay. Yeah and nay. The first thing is that technically SDS includes people who work in care at home and care homes, because they're option 3s. So they are, and they've found a job, and I think though, Kay, you're kind of the yes bit is that we've got a group of people who are prepared to take on some of the most challenging aspects of social care, don the blue gloves. So I call them the blue glove brigade, and they are prepared to go out and provide care and do they're the absolute gold dust in the system. Those people who are prepared to take on these roles and to carry out personal care tasks for folk is really, really important. But we need to complement them. So around about that, we need to be able to weave a whole lot of different types of care, because not everyone needs 4 visits a day for personal care, but people might need 2 or 3 visits a day nevertheless. And I think that what we need to do is to broaden the offer so that people can be involved in providing personal care if that's the job they want, but they can also be involved either voluntarily or through option 1s and 2s in providing different types of care, whether that's befriending, whether that's getting the shopping, whether that's just helping people live in the community. And it's about weaving a system of care around that concentrate. So I see it like a glass. You absolutely need some blue glove stuff at the bottom of it, but we need lots of other stuff too. And our difficulty is that we've been one club golfers. We've provided all our care through care at home and care homes. So we've just filled up the glass with concentrate, and we have not invited other people in. And actually, we really need to make the most of these personal carers who are, as I say, the absolute gold dust in the system. But we recognise, and this has been big out, is that there are small communities know each other and they know what other people are prepared to offer. We need to personalise our invite into social care is almost as much as we personalise the care that we provide to people. So we know, for instance, that there'll be young mums who drop their kids off who would be prepared to provide someone with a visit for a bit of befriending or to do a few tasks. That's the kind of thing that people would be prepared to do, but you need to know them really well, and you need to understand the time they got. They can't work a 4 on 4 off. That's never going to happen. They're never going to be part of that process. But if we have really clever, independent support, we could start matching care to communities and actually use it as an investment in communities. What it requires, though, is a lot of hard work and a lot of knowledge at the community level, not lots of system knowledge and lots of big operations taking. And it really needs to situate itself very locally, so it starts making those links. But without, we don't want to lose the carers. We can't lose them. We need to build around those blue gloves because they're the absolute stuff of it. But a little can go a long way if we were clever enough, I think.
Thank you, Ian. Maybe if I just round things off, I'll just say I tremendously enjoyed reading the report with us today, Ian. What really came across to me, and it may well be just the first time I've noticed it, but it felt as if actually what we were now talking about was self-support, and actually how we use all the tools in the toolbox as you've been talking about there, rather than talking about option 1 or option 2 or option 3. And it can be all of the above. Yep. And it's actually how we create that whole environment for the person who needs the support. So I was really encouraged by that. I actually also liked as well how you identified, and you and the others who probably fed into this, identified where we're creating the barriers and how we might actually be able to resolve some of those. And I'd be really interested to hear more of that next year. I think my final comment has got to be as chair of the committee, though, but in the context of I enjoyed the paper. It's an assurance report to the committee, and we don't have a level of assurance proposed to us. It comes to us to note, which we will certainly do. And I'm not going to put you on the spot and ask you to propose a level of assurance. But maybe just when you come back next to the committee, if we could actually have a level of assurance in terms of, and it may well be it's actually very difficult to do, because I've been thinking about that as I've been sitting here. How do you say where we are in what feels to be almost an ever-changing pathway? But you can tell just from the discussion we're having today, I think, how much we've enjoyed the report and what we're taking from the report. But if we just maybe think about that for future iterations of the report. But I see Ruth's got her hand up, and she may well want to comment on that.
Yeah, and obviously really interesting perspective, because I think from where I am, I think I can probably, in terms of this work in isolation, can give moderate assurance that things are going in the direction we'd like them to. However, in terms of where the papers are laid out today as well, if we look at this in the whole context, Ian's been talking about this being a grassroots approach, hasn't it? So actually, how are we looking at this in the context of the conversation and the information Pam was sharing with us, for example? So for me, I'm more challenged to give assurance in isolation on this because it sits within the broader context. So and hopefully that kind of makes sense to others as well. But I think we have to look at this. The success of this is going to be based on the other work in terms of our capacity and availability, and vice versa. We can't really look at them in isolation.
And I think that is a really, really relevant point. I think, Ruth, that we can't actually say, well, I can give you assurance on this, but the rest of this over here is not working well, and that must impact on what we're doing over here. So I think that's just maybe for Pam and I just to reflect on as we move forward. But I think overall, I'll bring us in. I thought it was an excellent paper, and I tremendously enjoyed reading it. And my thanks to Ian and the team for pulling it together. So thank you very much, Ian.
Thank you, Jerry. Tap.
Okay, we will move on to the Care Home Collaborative Annual Report, and I believe we've got Gillian with us, who's going to take us through this.
Super. Thank you, Chair. So the report in front of you covers two related but separate aspects around independent sector care homes. It provides a general market overview, but it also takes the opportunity to provide an update on the collaborative funding received from Scottish Government and also the focus and direction of that funding. And just before I go into highlighting some of the key points in the report, if we could just ask you to excuse the yellow editing highlighting, which has been included in the version that you've got. So to please disregard that. In terms of the overview, first of all, so we have 62 care homes across the partnership area, 46 are independent sector, 16 in-house, and collectively they provide 1,850 care home beds. We spend a significant amount on providing or purchasing that provision, so 54 million in total. And the vast majority, so 85% of those care homes, independent sector care homes, are under 50 beds, And in fact, just half of the care homes operating in Highland have 30 beds or less. So that gives you an indication of scale when you'll see why I've highlighted that as I go through some of the other key points. So over 23-24, we have continued issues around sustainability of small scale operators because we have many. So that continues to persist as an issue for us. Recruitment and retention continue to be a very prevalent issue. Reliance on recruitment from overseas and the challenges that brings with it in terms of cultural differences and changes, and challenges accessing housing, as well as access to staffing in remote and rural areas as well. Overall, the quality of provision has been good, as detailed in the appendix, but with a notable exception that we've touched on previously in the meeting, which is Cradle Hall Care Home. That closed on the 17th of April, and that followed the initiation of court action by the Care Inspectorate and the subsequent acceptance by the Inspectorate of the provider's voluntary deregistration. So this led to the relocation of 41 residents over 3 weeks, hugely challenging for all, and a distressing and anxious time for residents and their families, as we've acknowledged in the report. So in total, we've had 9 care home closures since March 22 and a loss of 211 beds. There is planned sector capacity coming on stream, notably with a new care home scheduled for spring 25. That should be in your report, not 24 as noted, and that will have around 58 beds. So as Anne has raised in a question earlier, in terms of our strategic direction, we have out of necessity to continue to react to rising situations, but there are proactive actions we need to be taking, and we are taking. So we are continuing to raise at all levels that the National Care Home contract, which is based on a 50-bedded care home operating at full occupancy, does not fit Highland. And we need something that does, or our market makeup will continue to struggle in the sustainable way that it is. We've also, in terms of another proactive action, been investing in recruitment to independent sector care homes through a dedicated Scottish Care post, which is starting to reap some benefits, and that's specific for independent sector, and it's basically to try and identify people who don't yet know that they want to work in adult social care and independent sector care homes, to go and find them, and to promote this area as one that's attractive to work in and rewarding to do so. And in order to achieve that, we need a number of the mechanisms around it, about where the information is, where people can access that, etc. So we're really excited about the potential for that post. And as as Pam had mentioned earlier as well, the other action that we're needing to progress is clarity on a forward care home strategy and intentions. And we have plans in terms of engaging with the sector as a very key stakeholder, not the only stakeholder, but as an absolute key stakeholder, to inform that process. So in terms of the collaborative support specifically, there's been funding from Scottish Government in various incarnations since 2020 around supporting care homes. This has moved more recently from an oversight focus to a collaborative focus, with the key objective of improving life for people living in care homes. We've had for the previous year 681,000, and for single year funding only. And that 1 year non-recurring funding is, whilst welcome, it is immensely challenging to build and sustain a collaborative care home support team. And we've consistently fed back these challenges to Scottish Government. Attracting and retaining staff on a fixed term basis in an already challenged recruitment market, I would say, is pretty much impossible. However, we have been directing the funding towards a number of areas, including that collaborative care home support team, and that team has existed to provide training and proactive support across nursing, physio, health protection team, etc. And that's been something that has been exceptionally valuable to the sector. And because it's not in existence in its full form at the moment, it's being missed very much so by the sector. Because of the difficulties recruiting, we had an underspend, and we redirected that towards a resident wellbeing fund. And I would commend the attached outcomes reports to you, which reflect the positive impact that funding has had, and really powerful beneficial statements, which has absolutely impacted on people living in care homes. So we'd absolutely commend that as a read. And also the independent sector career and attraction lead, which is what I mentioned just a few moments ago. I'd say we're really enthusiastic about what support that role can offer. So beyond those three elements which have been funded by this fund, we do have a wide range of other supports available to the sector, and they're as noted on page 27. And what we need to do is we need to make sure that we better coordinate activity and focus on a wider collaborative aspirations and opportunities to support care homes with the rising issues. And that specific direction is under consideration at the moment about how we best do that to bring everything together in a coordinated and embedded way. We know that the issues aren't going to resolve themselves on their own, so we absolutely need to be round the table with the relevant stakeholders creating the solutions for those issues. In terms of overall assessment, care home provision generally good or better across Highland, ongoing turbulence and sustainability issues, and we're looking to progress actions around sustainability, strategy and collaborative support aspirations. The report offers moderate assurance in relation to, I guess, those two specific issues, and that's because of the ongoing sustainability challenges, which are sadly not totally within our control. And then the second issue is around the single year funding from Scottish Government that we are heavily campaigning around. So here just to highlight the reports provided for awareness and assurance, and happy to take any questions. Thank you.
Thank you very much indeed, Gillian. I'll throw it open to colleagues for any questions, comments, observations. David.
Yeah, thanks, Gillian, for a detailed report. The two homes that I get asked about is the two that are temporarily closed, Struntian and Mallaig, Dalmore, Macintosh Centre. It'd be useful to get an update, doesn't have to be today, as to what we think the longer term position with these are. Thanks.
Great, no problem. I'm happy to work with Pam to provide a response on that.
That would be helpful, Gillian, if you could just update Councillor Fraser outside of the meeting. Stephen, could you say on those things we deal with outside of the meeting, I think if we copy all the members in just so they're aware of the issues. Thank you. Joe.
Thanks, Jenny. So just one minor point of detail in the report, it notes that podiatry was part of the team last year and it's missed out occupational therapy. So that's just a correction. Podiatry is a thought for this coming year. But I think on a general point around that care home collaborative funding, I think it's a really good example, although it wasn't the plan to have that wellbeing fund that people could access. I think that the dual approach of kind of what we know has the potential to improve the quality of life for individuals, along with what they're asking for and what they view as the things that would enhance their experience, is a really good model for us to be thinking about in terms of a number of the things that have come up in the agenda today, because actually we've seen really good feedback from both. So it's a nice example of that balance of the kind of what's the word I'm looking for, kind of professional view of what would improve things, and actually being really engaged with service users and providers around it. So it's just to commend that approach, I guess, to the committee.
Thank you, Joe. Anne.
Maybe person-centred was the word that Joe was struggling to find. That might be one that fits. I certainly agree with her that it was a really good example of use an imaginative use of monies that are not provided to us in the most sensible way possible. Thanks for the report, Gillian, and as I said, it's really interested in that aspect of it. I think we also have to thank the team that were involved in the closure of Cradle Hall Home. Again, sort of, a very pressurised situation for those having to deal with it and find other placements for the residents. So I think we need to note our thanks to that team. Just a couple of questions, Jerry, just on that point about the closure of Cradle Hall. I just wanted to ask whether it was felt there were any lessons for us as a commissioner to learn from that situation at all. And secondly, and more broadly, I guess, on the sort of wider care home strategic position, I think there's a real challenge for us here in terms of the locality approach that rightly is set out in the integrated strategic plan and the market realities that we don't control, where the independent sector are willing to or able, because of the sort of sustainability issues, to open homes. So, you know, for me in that context, the development of a Highland-wide strategy and market plan is really essential to set the context locally. And I just wondered what we think the timelines are around completion of that piece of work, which I think is really urgently required. Thanks.
Sure, if I'm able to respond to that, thank you. So, Anne, if I can pick up your first point first about the lessons learned around Cradle Hall, we're completely cognizant that whilst this has been the 9th one, this has been a very different one in a very different context and with different timescales. And we have been undertaking lessons learned of all of the prior ones, and we build on that. And we have an evolving standard operating procedure, which I think, as mentioned before, is normally for a 13-week closure, and this has been different and it's been an accelerated closure. So we are conducting 3 different lessons learned. So one looking at the period of time between the new provider taking over in October and the closure period. So we're looking at all the issues around that. We're looking at the relocation process itself, in terms of our internal workings around that, and the matching, if you like, of residents and to locations. And we're also undertaking a 3rd lesson learned, which is the sector response. So this is the first time that I made a personal appeal to all providers in Highland, when we knew that the care home was closing, and we could publicly share that information, to ask for their innovative assistance to prioritise placements because of the very short notice. I have to say the sector really stood up to that. In some cases, providers taking several residents and working with us really flexibly around that. So we're in fact on Monday next week, I'm co-chairing with the Scottish Care Independent Sector Lead a lessons learned of how that was for providers who were receiving residents from Cradle Hall. So we'll hopefully have some rich information from those 3 different processes. So that was your first point, and second was about the strategic direction, the strategy and the market facilitation plan. Absolutely, that is critical to our proactivity, because we have been in a very reactive space, necessarily so. But what we're needing to do is we're needing to have that kind of 5 to 10 year forward plan. We do know that with the makeup of market that we have a number of sole operators that I don't expect will continue to be around in the next 5 to 10 years. We need to plan for that. We can't ignore the fact that that just might not happen, and we need to be more, I guess, measured and open to recognising that is a reality, and we need to plan around it. So I'm hoping to have an in-person session with the independent sector over the coming month or 6 weeks, and to get their input on what models of care and what the sector could look like over that kind of time frame. And so I would hope within the next 2 months or so, and that we'd have something that looks like a kind of draft strategy and market facilitation plan as well.
Thank you very much, Gillian. I'm not seeing any other hands up, so I will ask colleagues, are we happy, content to note the report and take the moderate assurance which is offered to us? Lovely. I'm seeing lots of thumbs up. Thank you very much indeed, Gillian. We're running a little bit behind. I'm going to propose that we take the final item in section 3, the Children and Young People Services Annual Performance Report, and then we'll take a 10-minute break. So I think I'm handing over to Fiona Duncan, who's going to present this report to us. Thank you very much.
Sorry, Jane, it was actually Jane Park that was going to present this today because Ian's actually off sick, unfortunately.
Oh,
so Jane's here. So
apologies, Fiona. Thank you, Jane. Welcome.
Oh, thank you very much, committee members, and thank you for having me. You will note that I'm not Ian Kyle, and I'm definitely not Fiona Duncan either. The report that you have to today, just by way of general introduction, this report has already gone to the Community Planning Partnership Board for ratification in March, I believe. This is the required annual report for the Integrated Children's Service Plan. It has also gone through the Joint Monitoring Committee. I recognise that there might be some discussion about the way round about there, and I think there might be a need to review that, given that this committee is now seeing that after both the Joint Monitoring Committee and the Community Planning Partnership Board, who signs that off. So I will certainly take that back for a conversation to the chair of the Integrated Children's Service Board. The report itself gives you just a little bit of a general background to that. It was drafted by Ian for the board, and the plan that's attached on also has the performance management framework there. Many of the committee today will already have seen the report and the plan that's there. Just by way of general background, the plan itself in Children's Services takes a life course approach. That's quite a shift for Children's Services, but it does recognise that to support and protect children and young people, we also really need to start shifting our thinking to whole family support and whole community support. So the Integrated Children's Service Plan is built around a life course approach to the very early years, school years, and through into adulthood. The very positive news about that is that is aligned to the education plan. It's also aligned, of course, to the NHS plan. So we were trying to keep things aligned up in terms of Integrated Children's Service planning. The only other thing I perhaps would mention is that the delivery of this plan is key, in that we recognise as an integrated planning board, it's all very well having a nice plan and doing the engagement, and a lot of engagement was done with families as well as with staff and across the partnership. But actually the delivery of the plan is key here. So there are a number of partnership delivery groups, given the governance route here. The HOIP delivery groups around mental health and wellbeing are looking after the children and young people aspect of mental health and wellbeing, as is the poverty group from the HOIP delivery groups. We of course have the Child Protection Committee and the Drug and Alcohol Partnership. So a number of the key partnerships groups feed into the Integrated Children's Service Planning Board and performance framework for delivery of the outcomes to the plan. It is quite a complicated landscape to try and navigate. However, on a very positive note, the Integrated Planning Board is represented by stakeholders from across the partnership, into the NHS, third sector, education, health and social care, and the police, all around the table in terms of integrated children's service planning. So I'll stop there. I can't promise to be able to answer all the questions. There is the performance management framework that has currently been agreed at the back of the plan. I'm happy to take any questions. I might be able to help more around that, but I'm happy to take any questions around that if that would be useful, or indeed to take questions away and come back to any of the members with answers if that was needed. Thank you.
Thank you very much, Jane. And you're right, this report has already, I would say, I've seen it at JMC, and I'm sure other colleagues have seen it there and other places. So I think you're absolutely right that we probably do need to have a discussion about what is the best route for this report. But on the specifics of the report, I'll maybe just throw it open to colleagues for questions, again, comments, observations. Oh, looks like you're going to get off well here, Jane. I'm not seeing any specific. Ian never gets off this easily. Anne.
Well, I think probably this is a reflection of the fact that the paper's already been to several places where several of us have seen it and discussed it in some detail, Jerry. So I suspect that's the reason for. I think it's probably the report itself doesn't propose to be offering this committee any assurance, which is appropriate, because our job is to assure the board about the delivery of the children's services that are commissioned, that are delegated to the council in terms of child health. So it's the one thing I would say is it is appropriate. The context in which it's presented to us is not for assurance, but I think poor Jane's sort of nothing personal, Jane. I think it's just you're lucky enough to be doing this responsibility when we've already been round this a number of times.
No, I think that's a very fair comment, and I think we've got a meeting of the chairs of the committees of NHS Highland tomorrow, and I think I'm intending to raise this issue again tomorrow, in terms of, because it's not helpful to anyone to have the same report going to multiple committees. Let's agree a governance route and how we can take that. And I was actually also mindful as well, and this maybe is a question for me to ponder on, and maybe Anne and Philip and Joanne, if they want to, is whether our terms of reference, which is, can you actually isolate the delegated services from integrated children's services to offer assurance on them, especially as we move towards, I think, what, as Jane said to us, that whole family approach as well, whether the actual question we come up with however many years ago is probably no longer appropriate. So on the basis that there is no comments, questions, observations, we have been asked to note the report, and we will note the report. Thank you very much indeed, Jane. And again, I'm sure you will pass on our thanks to Ian, and we wish him well as always. And with that, I will eat into your tea break slightly. Can we take a 9-minute break and be back at 3 o'clock? Because I think actually it's not quite the second half of the agenda. I think we should be able to move through it fairly swiftly and give you some of your afternoon back. But if we come back at 3 o'clock, thank you very much indeed, everyone.